schedule was sent out, so the schedule is available. I guess it just isn't. It isn't available to IT. IT maintains the app. I guess they haven't quite gotten hold of it yet, or something like that. It's just, yeah, very strange. Very strange. Jazz, can you hear me all right? Yeah, I didn't hear that, Jess. What's my, yeah, no? Okay, so. Can you hear me, Stephanie?
Yes, I can.
Good. All right. Okay. Let's go here. Okay.
All right. So there were two documents. I printed this one. I think this is enough.
Okay.
Front back, because this gives your session time.
No, no, do it, everything.
So I think that that should be good.
Okay, great.
Okay.
Cheers.
There you
All
go.
right. I've graded the ones I've gotten.
Yeah, I think the same as mine. And I was probably just running a little hard.
Okay. Okay.
Yeah.
That's field house.
Yeah.
Yeah. Front desk. That's the schedule for Focus. They were supposed to email it to everyone, and they've not done that. And the other thing I heard is that it was going to be on the app, and it's not on the app either. So you have to go to at least 3 either workshops or plenaries or whatever. So the 2 plenaries are Roger and Paul Nemechek, and then the workshops are here. You can do 2 workshops and 1 keynote. You can do 2 keynotes in 1 workshop. You can do 3 workshops. You can do just 3 of something. You do have to write a summary, a brief summary, like brief. You should be able to do the whole thing, I would hope, in 500 words. All 3 in 500 words, I would hope. You have to go to 3. So shoot for 500 words. If it's over 500 words, try to keep it below 1,000. So that's your range, 500 words to 1,000. Brief summary, the operative word being brief And all I want is a summary of what the person talked about. I'm doing a workshop on medical information, how to try to separate the wheat from the chaff. Rather tall order, but given what we've just come through, I suppose it's necessary. So.
We don't have classes on Wednesday.
No, you have focus. You are focusing on this one topic, which the topic this year is crossroads, coming to a crossroads. Sorry? We have farm in the evening. Yeah, evening classes don't meet. So the old saying goes, when you get to a fork on the road, take it. I'm sorry? We'll have a quiz for farm. Yep. Farm will be just as it usually is. So it was told to me that you guys had not received the standard email with the schedule, and the app was supposed to have the schedule, and it's not yet up. And some folks were getting a little nervous, I guess is the right word, about what it was they were supposed to do. So the good news is, if you have a 7:45 class, you don't have to go to it, but there's a workshop at 8. So if you want to go to the early workshop. Chapel, the keynote is in place of chapel.
Oh, so we could write something about that.
Yeah.
Oh,
Yeah.
okay.
Yeah. I think Roger's no, Paul is Paul's the one for Wednesday, and then Roger's the one for Monday.
Do we have chapel Friday?
No, I think not terribly savvy on the chapel schedule. I think it's just Monday, Wednesday that week. No, because the chapel focus is the chapel. Right, you get a twofer. Oh, it's now called the Arbor Church. They're still calling it Spring Arbor Free Methodist Church. It's the Arbor Church. It's the one across the street. Yeah, old habits die hard. There it goes. Okay. I think that's everyone. Yeah. Good. All right. Terrific. All right. Okay, folks on Zoom, do the slides move if I do this?
Yeah, they're
no?
fine.
They're fine.
Yeah,
Okay,
I can see them.
excellent. Okay. Okay, so we talked about some of the things that increase the risk of breast cancer. We talked about some of the phenotypic features. We saw that the inheritance of breast cancer is autosomal dominant. If you have an inherited tendency to have breast cancer, you will tend to have an early onset breast cancer. The triple negative ones that have neither amplification of the estrogen or progesterone receptors and amplification of the HER2, human epidermal growth factor 2 receptor. Those triple negative ones are the most aggressive. Family history of breast and ovarian cancer, because the same sets of genes tend to be involved with the onset of both types of cancers. Yes, great. Same chapter, I just changed the look of the slides so that, chapter 7. Yeah, no, I changed the look because this is a little boring, I thought, just white lettering. This is more colorful, isn't it? Yeah? Should I not do that, or? I thought you guys like color. Oh, okay, okay, all right. If you have an inherited tendency for breast cancer, then your risk is increased for bilateral tumors. There are certain breast tumor types we'll see that tend to appear more often in people who will have bilateral tumors on both sides, tumors in both breasts. Some of the genes involved with breast cancer, certain alleles of those genes also increase your risk for ovarian cancer. And some of these will also increase the risk of male breast cancer. Male breast cancer being pretty rare, there are, however, certain alleles of certain genes that can increase the risk of breast cancer. In particular, individuals from this Ashkenazi Jewish ancestry, they tend to have alleles because of something that we'll talk about called the founder effect that will increase their risk of cancer. I want to now talk, I just added these slides today, so don't worry if you don't have them, although I did update the PowerPoint. I want to talk about some of the different types of breast cancers. There's two main types, non-invasive and invasive. And oh, you're kidding. Oh, I left it upstairs. Wait. All right, so there's three types of non-invasive breast cancer. There's the ductal carcinoma in situ. There's something called Paget's disease of the breast. Then there's lobular carcinoma in situ. Let's talk about the DCIS, ductal carcinoma in situ. So in this case, you have a cancer that has not crossed the basement membrane and invaded under other tissues. This is a precancerous lesion. It's characterized by a mass of neoplasial cells, as you can see there, inside the lactiferous duct. They proliferate and they tend to fill the lumen of the duct, but then characteristically, and there's two main types of the ductal carcinomas. There's called There's comedo ductal carcinoma in situ, and there's none. So with the comedo ductal carcinoma in situ, the neoplastic cells will fill the duct, and then the center of that mass of cells undergoes cell death, and it calcifies. And because it calcifies, you tend to get a center that looks like a kind of concentric fibrotic calcified node. And so that's the reason why in a mammogram sometimes, if you see little calcified nodes, that can be an indication of DCIS. This type of tumor does not tend to produce a mass lesion unless it's invaded surrounding tissue. Instead, it's usually identified as a little microcalcification on a mammogram. Now, in contrast to the comedo DCIS, the non-comedo DCIS will have these little kind of finger-like growths, bless you, that kind of just grow into the center like that. And those finger-like growths, instead of occupying the whole duct and then having a piece that's kind of died in the center, you've just got these kind of little fingers. And sometimes those little fingers can have gaps in between them, or they can, in some cases, completely fill the duct. If they do fill the duct, you don't get the death in the center. So that's a ductal carcinoma in situ. That tends to be a precancerous sort of condition typically. If it starts to invade and breach the basement membrane, then you start to have trouble. That's essentially what the pathologist will look for. Do you see a nice intact duct, or do you see cells outside the duct? Yes.
How can you tell, like, what the duct looks like just from this needle?
So usually if you have a little microcalcification, you'll have a needle biopsy of them. And then the pathologist, essentially, this material here is essentially a type of exocrine gland because it secretes its materials into a ductal system. So exocrine glands have a histology that's pretty easy to see. Once you get on the slide and you section it, you fix it and stain it, and so on and so forth. If your ductal sort of system has cells in it like this, and it's pretty clear it's not the result of fixation, because fixation, usually the cells will kind of fold like that. If there are cells growing into it, that tells you you have a ductal carcinoma in situ. Then you can do stains. So stains can also be very informative as well. That's a whole field unto itself, is pathology. Now, the Paget's disease of the breast essentially is a tumor that starts in the lactiferous gland, then it grows down the duct towards the nipple, grows down the duct toward the nipple. So it extends into the nipple, and so it will commonly present as a eczema on the nipple, essentially. So if you get this eczema on the nipple, essentially, that refuses to resolve, that can often be a sign of Paget's disease. You're going to diagnose this once again with a biopsy. It's usually treated with a mastectomy. Paget disease tumors tend to be responsive to anti-estrogens, typically. But the scaling, flaking of the nipple, eczema of the nipple, that's a sign usually of Packett's disease. Does that sound similar to the case study, one of the case studies we read? Take a look at the second case study when you get time. That might give you a little hint of what's going on here. Okay, so the lobular carcinoma in situ tends to not produce a palpable breast lesion that you can feel on a self-examination. Instead, it's usually found as an incidental finding on a biopsy, typically for something else. If you have lobular carcinoma in situ, it increases your risk of having such lesions bilaterally in both breasts. And in this case, as you can see, instead of just having the duct that contains cells, it's the entire lactiferous lobule in this case. So with the ductal carcinoma in situ, you'll see one duct usually that has growth in it. With the lobular carcinoma in situ, it's going to be in the entire lobule. Again, they haven't penetrated the basement membrane yet, so it's precancerous. And that takes us now to the invasive cancers of the breast. So these are going to present usually as firm, palpable masses in the breast. The cells will be pretty poorly defined. And as the cancer penetrates the surrounding tissue, it can penetrate the pectoral muscle. It can also penetrate the suspensory Cooper ligaments, and that can lead to retraction of the overlying skin. And if the cancer cells obstruct the lymphatics that drain the mammary tissue, they can essentially cause lymphedema. And because of the stretching of the skin can have this kind of dry look, and it's given this rather terrible name. The only redeeming factor of it is that it's in French, and it's peau d'orange. Which means skin of an orange. All right, so the first of these is the invasive ductal carcinomas. And the invasive ductal carcinomas they can be either tubular or they can be mucinous. Tubular or mucinous. The tubular carcinomas are characterized by lots of very well differentiated tubules, except they lack the layer of myoepithelial cells on the outside that contract. And so that's a tip-off for the pathologist. Do you see essentially the myoepithelial cells on the outside? You don't. That tells you essentially you have an invasive ductal carcinoma. And notice the cells are spilling out That's the other tip off as well. The mucinous ones are just what they sound. You have a sea of cells embedded essentially in a matrix of extracellular material. The mucinous invasive ductal carcinomas are more common in older women who've undergone menopause. So mucinous M post-menopausal. They're the ones most likely to get the mucinous one. And the M may help you remember that. Maddie, was that a question? Or no, you just did. Waiting. Hi. Okay. All right. So the next type of invasive carcinoma is a lobular invasive carcinoma. Lobular invasive carcinoma. This is the second most common type of invasive breast cancer. Oh, incidentally, if males get breast cancer, it's usually invasive ductal carcinoma. This type of breast cancer is not palpable on a self-examination usually. These and this picture here, I think, does a good job of showing this. The cells are in strands or chains on histology. You can see that nicely here. Well, chains essentially that kind of move a bit, but you see the kind of strands of cells. That's really common with the lobular invasive carcinoma. And one of the molecular traits of this type of cancer is they lack a cell adhesion molecule called E-cadherin. So they're E-cadherin minus. I don't have a slide of the next one. This is called medullary carcinoma, and this is going to be important for our discussion. Medullary carcinoma has a palpable mass, but it appears in younger women, and it tends to appear in women who have mutations in BRCA1. In this case, you see cells that are really poorly differentiated. These cells are called anaplastic cells. Anaplastic cells. Finally, there's inflammatory breast carcinoma. This tends to affect women younger than 40. And this particular type of cancer tends to cause the eruptions on the skin that range from deep red to purple to pink. And these women often present with the peau d'orange type of skin. Now, if the tumor doesn't have a palpable mass, they can be mistaken for mastitis. Inflammatory breast carcinoma is always invasive, always aggressive, and the symptoms are caused by blockage of the lymphatics. All right, so those are the different types of breast cancers, non-invasive and invasive. Medullary one, I want you to keep under your cap because that's the one that's involved with the BRCA1, BRCA2 mutations. Okay, pause right here. Any questions? No? Very good. All right, so your tumor suppressor genes, if you have a loss of function mutation in the tumor suppressor gene in the germline, as the cells divide and you make a person, those cells can, with lots of cell divisions, lose the chromosome that has the wild type copy of the gene and replace it with the chromosome that has the mutant copy on the gene. Now you might think to yourself, boy, that sounds like that shouldn't happen very often. Well, it doesn't happen very often. But in order for you to now have complete loss of function of a tumor suppressor gene, it only needs to happen once. And so it happens at a high enough frequency so that with thousands upon thousands, even millions of cell divisions, it can happen. So if you have a tumor suppressor gene mutation, and if it's in the germline, you can have the occurrence of a second mutation that can cause the overgrowth of tissue wherever that tissue is. Cancers like this can seem to skip a generation because some people may have that second event, some people may not. And because that mutation is heterozygous, you have a half a chance essentially of passing it on to the next generation. Exposure to other types of things that can cause errors in cell division can increase the risk, of course, of having such a tumor. And I wish Bree was here because she's had to deal with retinoblastoma. Retinoblastoma is caused by precisely this event. So Bree is heterozygous for the retinoblastoma mutation. But as the eye forms, you can get a loss of function mutation that occurs in the cells that make the retina. Was it inexorable that it would happen in Bree's case? No, but it happened to happen. And she had a tumor in the retina and it was surgically removed, saving her life. And now she has one eye that doesn't quite work. So this is the story also with BCRA1 and BCRA2. And as you can see, mutations in these genes are not only associated with breast cancer, but lots of other cancers too. So ovarian cancer, colon cancer, and also prostate cancer in men. And then BCRA2, which is on a different chromosome, chromosome 13, it's associated with male breast cancer, ovarian cancer, prostate cancer, and pancreatic cancer. And these cells are involved with cell cycle specific DNA repair. They're associated with recombination repair that repairs breaks in the DNA backbone without introducing any mistakes into the sequence. When you don't have proper functionality of these proteins, your DNA repair is not as efficient as it should be. And that can introduce mutations and cause the production of tumors. So this essentially, these tables simply show you your increased risk. We went over some of these numbers before. You can see with BRCA1, you have a substantially increased risk for breast cancer in females and a slight increase in males, 40% increase in ovarian cancer, lifetime risk for cancer on the opposite side as well is pretty high. And then increased risk also for other types of cancer, prostate cancer. And then BCRA2 increases the risk of male breast cancer about 8 times, substantially increases the risk for ovarian cancer and pancreatic cancer, and then other types as well, stomach, melanoma, prostate cancer, blah, 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 so on and so forth. Now, are these the only genes involved with the onset of breast cancer? The answer is no. These are some genes we're going to see again next chapter when we talk about colorectal carcinoma. But these 3 genes here are tumor suppressor genes. These genes encode proteins that tell the cells to stop dividing. They put the brakes on cell division. If you lose functionality in these genes, that increases your risk for breast cancer. So if you have germline mutations in these genes, and there are good commercial screens available to detect that, you can essentially assess someone's risk. Also, there are mutations in genes that encode components of something called mismatch repair. Mismatch repair. Now, mismatch repair, if you get bases that somehow get chemically altered so that they don't quite fit together in the double helix, they create a bulge in the double helix. And mismatch repair proteins combine to the bulge, and they can chip out the errant base and replace it with the right base. So if you have mutations in these genes that encode components of mismatch repair, you have an increased risk of ovarian cancer. MSH2, by the way, is also huge when it comes to colorectal carcinoma as well. Mutations in this called something called familial polyposis. And that greatly increases your risk of colorectal carcinoma. Yeah.
So when should somebody go about like deciding whether they should get the
Family history. Family history. Family history is really going to be huge. And what if someone's adopted? Then it's kind of black box over there. So you really have to ask yourself, if someone has tumors really early in life, they've got increased susceptibility, they should be tested. If they have cancer on one side or both sides or something like that, and it occurred when they were young, they should get tested. And your job as a nurse will be to take the family history, essentially to ask the right questions, so that the genetic counselor, the oncologist, or whatever, can essentially decide, yeah, let's go ahead and get tested. Also, because they have those risk factors, insurance will pay for it, because the genetic tests are not cheap. To have someone to pay for those is a tall order, and insurance have strictures on this to make sure people just don't go out and ask for any old test. They have to have reasons for that test. So you're working with them essentially to provide evidence for the insurance company, to the insurance company, so they'll pay for the test. It really is that simple sometimes. That doesn't mean the family history is not important. It is. It's huge. It's really huge. They're very good commercial tests for BCRA1 and 2. Very good. These tests are very accurate. They do a good job, and they're pretty widely available. So some 5 to 10% of women will have usually BCRA1 or 2 mutations. Another 4 to 7% may have mutations in some other gene that may increase the risk also of ovarian cancer as well as breast cancer. 10 to 15% may show some sort of mutation that has an unknown significance. So whether that's important or not kind of remains to be seen. Now, there are certain lineages where the tendency to have these particular mutations is higher. because of the founder effect. The founder effect, I think, is relatively simple to understand if we use, say, a really odd example. And the example goes like this. So the father tells the story about the Christmas ham that his mother used to make. And she used to make it a certain way, but she always used to cut the ends off it. And so he told his wife about this way. And so she, oh, okay. So she cut the ends off it. That's why she made the Christmas ham. And so this was the secret. This was some big secret. Why did cutting the ends off the ham kind of make it so good? Well, then her daughter grew up, got married, had kids. And when it came time for Christmas, she'd make the ham and she'd cut the ends off that way. And then when her daughter got to the point where she said, you know, Mom, can you teach me how to cook? Sure, let's cook the ham. And Mom, why do you cut the, well, because that's the way my mother did it. And it's really good. And then finally, one Christmas, they were able to have great grandma in the house. And they said, great grandma, why did you cut the ends off the ham? She said, well, I never had a pan that was big enough to cut the whole ham, so I just cut the ends off. Now, that's a very silly story, but it shows you essentially how something that's found in a founder population, say a founder population had a spot on the top of their head or something, but the rest of the population, not many of them had that spot. But then as this founder population established a new population on an island or, you know, wherever, all of those, their offspring have spots on the top of the head. That's called the founder effect, where rare alleles in a population, because they happen to be present in individuals that happen to escape and establish a population, those rare alleles are now the main alleles in that new population. So the Ashkenazi Jewish heritage, because of the bottleneck they went through because of the Holocaust, you had certain individuals who survived. So certain individuals who survived live largely in Israel now. They tend to have groups of alleles because it was a very small group of them, and they happen to have, that group that survived happened to have the BCRA1 mutation. Same thing with the Icelanders. So people who founded Iceland were Vikings, and they were a founder population of the greater Viking population. The Vikings were not just Norwegian, they were also Swedish and Danish. They were pretty diverse when it comes to the Germanic tribes, but you only had a selection of them that went and founded Iceland. So the modern day Icelandic people are descended from a founder group from the Vikings, and they happen to carry BCRA1 at a higher frequency than you find elsewhere. So if you find people who have these particular lineages in their ancestry, that's a good reason to have them tested. And if you don't know what your heritage is, you can get 23andMe testing, and 23andMe, which is not that expensive, can tell you essentially what your heritage probably is based on DNA markers that you have in your genome. So if you're wondering, oh, gee, what am I? I'm maybe a little of this, a little bit of that. If you're ever curious, you can just go to 23andMe and swab the inside of your mouth and put it in the mail, and there you are. So these ethnic-specific mutations, there are testing panels that are available. They're specific for particular lineages. So you have to know the lineage first before you order the panel, because the panel is for certain ethnic backgrounds. And so in the general population, you have this frequency of BCRA1 or BCRA2. But in the Ashkenazi population, you can see it's 10 times more. You have 10 times higher risk of carrying this. So these ethnic-specific testing panels can be remarkably useful, provided somebody knows their lineage. If they don't, again, you can do 23andMe to find out. Now, insurance usually will not pay for 23andMe. That's the downside of that. But it can be really useful if someone was adopted or something like that, and they just don't know their family heritage. We've talked about penetrance already, but penetrance for BCRA1 and 2, as you can see, for breast cancer is higher than it is for ovarian cancer. That's why these particular types of cancers can skip generations in some cases. And then there are other types of genetic syndromes that increase your risk of breast cancer as well. Now, some of these syndromes we're going to see again next chapter. So the Li-Fraumeni syndrome is due to a germline mutation in the p53 gene. p53 is a really important protein. It's called the guardian of the genome. What p53 does is when it's time for your cells to divide, p53 goes around the chromosomes and it counts them. And it makes sure that there's 2 of each one. And if there's only one of them, it doesn't let cell division go. If there's 3 of one, it doesn't let cell division go. So it's called the guardian of the genome. Guardian of the genome. p53 is one of the genes that gets lost earliest in certain types of tumors, because then it lets you play fast and loose with chromosomes. So people with germline mutations have this condition called Li-Fraumeni syndrome. You're at higher risk for each of these different types of cancers, and it increases your lifetime risk of breast cancer by 50% by the time you're 60 years old. The PTEN tumor suppressor gene is related to a couple of different, well, actually a few tumor syndromes. The interesting thing is that some of these tumor syndromes have very different phenotypes, but they're due to mutations in the same gene. So yeah, genetic background probably plays a big role in the expression of this particular tumor syndrome. So PTEN is a tumor suppressor gene, and if you don't have the PTEN gene, you're subject to all kinds of soft tissue tumors. That's what a hamartoma is, it's a soft tissue tumor. And you have an increased risk of cancers of the GI tract, endometrium, colon, kidney, thyroid, blah, 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 so on and so forth. You tend to have skin issues as well. And then it also increases your risk of breast cancer in women as well. Now this one, the Poitiers syndrome, this tends to cause an increased risk of tumors in the colon. So we're going to see this again next chapter. This is due to this kinase, STK11. It's on chromosome 19. People who have a mutation in STK11, if you look inside their mouth, they've got black spots on their gums. That's one way essentially to tell if someone has this particular syndrome. So you have the melanotic macules, lips, oral cavities, so on and so forth, and what have you. They also tend to have multiple polyps in the GI tract, but there is an increase essentially for breast cancer in women that you can see is pretty substantial, 55%. There's also an increased risk of early onset ovarian cancer as well. Others include this condition called hereditary diffuse gastric syndrome. Yes, it's gastric. It tends to cause increases your risk of a very highly invasive GI cancer, but it increases your risk of lobular breast cancers in women, in particular your invasive lobular carcinoma. And CDH1 is actually the gene that encodes E-cadherin. Notice that that increases the risk of breast cancer pretty substantially. And looky here, here are our old friends, these mismatch repair genes. So mutations in these cause something called Lynch syndrome or hereditary non-polyposis colon cancer, which is mercifully abbreviated HNPCC. And so these cause cancers throughout the GI tract as well, as you can see, but also endometrium, ovaries, and then it can increase your risk of breast cancer as well, albeit not nearly as much as the other conditions we talked about. Lynch syndrome tends to make its presence known in the GI tract long before it ever affects the breast. So let's talk about management now about these people, if you have someone with a BRCA1 or BRCA2 mutation. So you have a mutation present, but there's no history of breast cancer. So it's probably a new mutation. So management in this case usually involves pretty intensive breast cancer screening, even at a young age. Also, bilateral oophorectomy, salpingectomy, between the ages of 30 and 40, once childbearing is complete. Essentially, you have your kids and you have a hysterectomy. Bilateral mastectomies, if there's no personal history, are an option, but they're not recommended. But hormonal and surgical risk reduction is an option. And then with men, you have screening for breast and prostate cancer as well. And some men, I was talking to my urologist about this. Apparently some urologists will do actually prophylactic prostatectomies. Although my urologist said he wouldn't recommend it. He just said, in his words, quote, "Our screening these days is very good, so I would recommend intense screening rather than going whole hog and just taking the prostate out when there's no evidence of cancer yet." What if you have a personal history of breast cancer and you have a BRCA1 or 2 mutation? So now you're looking essentially at a recommendation for a prophylactic mastectomy and prophylactic hysterectomy, essentially. And that's in premenopausal patients. Also adjuvant therapy with tamoxifen or other types of aromatase inhibitors and what have you. Bilateral mastectomies are not recommended, but ipsilateral mastectomy of the affected breast, that's usually what's recommended. Not just taking out the mass, but actually taking out the whole, removing the whole breast. So breast cancer screening in cases like this should start at age 25. Normally, you're supposed to start at age 45. Now, in this case, you're starting at age 25. Mammography then start at age 30. And MRIs of the breast 6 months after the mammography, beginning at age 25 if you are a carrier of BRCA1 or BRCA2. Yeah, but it depends on your personal history. If you're male, and you have these mutations, you're going to screen a lot earlier than that. For ovarian cancer screening, there is a antigen that is found on ovarian tumors, ovarian epithelial tumors. It's called cancer antigen 125. It's very sensitive. It's also very easy to detect. You can detect it in blood. You should have that screening every 6 months, starting at age 30. Or if someone in the family had their earliest ovarian cancer, say at 25, then you should start your screening at 20. You should do it 5 years before the earliest cancer. These techniques don't necessarily detect ovarian cancer at early stages, but they're better than nothing. And for that reason, once childbirth is completed, a prophylactic hysterectomy is essentially recommended. For males, and this gets back to Natalie's question, you have monthly self-exams starting at age 35, clinical breast exams every 12 months starting at age 35. If the guy has gynecomastia, then you want to consider an annual exam, and then prostate screening starting at age 40. Guys should be getting a digital exam by age 40 anyway. And if BCRA2 is present, then you should start having screenings. That means PSA with a digital exam. And if need be, a stereotactic ultrasound guided needle biopsy every year as well. So tamoxifen is the drug of choice for chemoprevention. That's used if the patient does not choose to have the mastectomy. It's not as effective as the mastectomy. Not recommended in men. But the prophylactic mastectomy is the recommended option. It should be discussed, but once again, is it your decision? No, it's the patient's decision, and you have to be okay with that. So it's preferable to test if testing is warranted, to test them as early as possible. And if the BRCA1, BRCA2 mutation is positive, then they're at increased risk to develop both breast and ovarian cancer. If it's negative, they have the same risk as the general population. There are mutations that are not detected due to the limitations of the test. And they also may have a mutation in a different gene that may increase their risk of breast cancer. Just means if they get breast cancer, it's not necessarily due to BRCA1 or BRCA2. So again, these tests have limitations. Always acknowledge those limitations. So when should you identify candidates for genetic counseling? If you have someone in the family with breast cancer and they have a known mutation, yep, candidate for genetic counseling. Breast cancer diagnosed younger than 50 years of age, yep, genetic counseling. Triple negative breast cancer diagnosed before the age of 60, definitely genetic counseling. 2 or more primary breast cancers. Oh, doggy. Yes, sir. Genetic counseling. Males that have BRCA1, BRCA2 in the family, definitely. And if they have breast cancer diagnosed at any age plus any of the following, you can read here just a close blood relative that had breast cancer before the age of 50, close blood relative with any ovarian fallopian tube, primary peritoneal cancer diagnosed at an early age, 2 close blood relatives with any breast, pancreatic, prostate cancer diagnosed at any age, or if they originate from a population at an increased risk, Icelandic, Ashkenazic, Jewish, so on and so forth, blah, blah, blah. Any of these are candidates for genetic counseling. So your predest means you're going to do a pedigree. And from that pedigree, you will do risk assessment. And there's a nice little program called BRCA-Pro. You can put that information from the family history into BRCA-Pro, and it'll give you whether or not they're a candidate for genetic testing, which is pretty handy. Since nowadays, a lot of nurses are carrying around iPads. You can have that on your iPad. You can just put it in straight from the history you put in, take the file, put it straight into BRCA-Pro, and it'll tell you it right there, which is pretty handy, you must admit. The criteria is the criteria used by the NCCN. The NCCN website, by the way, is a really good website if any of you are interested in oncology. Okay, so what are the ups and the downs of the BRCA1, BRCA2 testing? It'll identify somebody who's at high risk, and it'll identify non-carriers in families where it's known that somebody has a mutation. In that case, it can relieve anxiety, but if you detect it early, then you're warned, and you can take precautions. Limitation, does it detect all mutations in BRCA1, BRCA2? No. It detects most of them. Does it detect all of them? No. What if you develop a BRCA1, BRCA2 mutation in your breast tissue sporadically? Will these tests detect it? No, no, because you're not testing a breast biopsy, you're testing cells from the inside of the mouth. So you're testing germline mutations, not somatic mutations. If insurance won't pay for it, then it might result in some psychosocial economic harm, so on and so forth. That's becoming less and less the case since most insurance policies are paying for it. And even Medicaid and Medicare, if you meet the standards, will pay for it. Okay, just our summary essentially. If the individual has inherited BRCA1, BRCA2, they're at increased risk, but there are things they can do to decrease their risk. These are tumor suppressor genes. We talked about oncogenes, tumor suppressor genes. Those are tumor suppressor genes. And the two big ones that have been identified, BRCA1, BRCA2. And after gender and age, family history is your biggest predictor for risk of breast cancer. Okay? Monday, we'll look at colorectal carcinoma. And we're going to see some of the same principles. Okay, gang. Thanks for coming to Zoom. I have some assignments for you to get back, so hopefully when I see you next, I'll remember to give them back to you. So have a good weekend, both of you, and stay well.
Thank you.
Thank you, you too.